pain is coming from in the joint. But it depends the lesion. So I'm not convinced that if you have a lesion with a full cartilage cap on it, that injecting the joint's going to do anything. There's no nerves in the cartilage, and if there's no communication with the lesion, it may do nothing. And so I've had a very strange, collection of responses to that. Some people get better, some people don't. Again, I think it might be synovitis in a lot of cases. So maybe those people do get a little bit better. We are approved now for, have you guys heard of osteochondroplasty, which is the guided injection of bone cement into subchondral lesions. It's theoretically approved for bone edema. That's what Americans are using it for. There's almost no data using it in the foot and ankle. There's a registry. So we're going to be a part of the registry, I think, if we get approval. We're approved to use it now here. I don't really use it in the knees. I'm not sure it really does anything in the knee. The data is pretty bad. I think it could be an option for some of these chronic lesions with cysts in them. I think the talus is actually a potential, at least to research and see where it could help. The concept behind it is you put bone cement in, and there's no longer this sort of gravity or mass effect on weak bone, causing theoretically bone pain and bone edema. I think it at least kind of makes sense in the talus. In the knee, you very rarely see cysts, whereas opposed in the talus, you'll see really very little arthritis and cysts in these quite often. And the knee, if you're starting to see cysts, they're usually arthritic. I'm not even sure I can remember seeing a big cyst in a knee.
And specifically into the subchondral cyst that you're...
I would put it into subchondral cysts. Yeah, I have 2 patients now that are thinking about it.
And how big are these subchondral cysts that you're...
They're small.
Yeah.
Yeah, so we have a 3D, like a revolving CT, an O-arm.
Okay.
And so I use an O-arm to localize the location of the lesion. The classic way, actually, is like the way that most of the Americans are doing is they just do it blind. They measure it off the CT scan or the MRI, and then hopefully that you put it in, because it's put in retrograde. You can't put it in through the joint. Mm-hmm. You can put it in through the joint, but if you put it in retrograde and the cartilage cap or the subchondral bone is violated, it'll start to come out of the joint. Fortunately, it doesn't set, and you can get rid of it very quickly.
Is it an attachment on some of your arthroscopic equipment?
No, it's a needle, localized needle, and it's just like it's like a plunger.
Yeah.
Trocar.
Gel.
Yeah, it's almost like a toothpaste, and it turns
similar
into
to what you use for like tibial plateau fractures.
It's exactly the same stuff as tibial plateau fractures. So my thinking was when we were going to start it was, I would at least like to know I'm putting it where it's supposed to go. I'm not sure if it's working, if it's going to work, but we should at least put it where it's supposed to go.
Gotcha.
Anyways, back to this case. So, what to do about these. I would let them rest most of the time for quite a bit. This person has ankle instability, I guess. I don't remember this full case. So these are interesting ones when you come to them on surgery. There are some surgeons which I don't totally fully understand, but often you will have trouble finding the lesion. So sometimes it's very obvious when you go into operate on these. I usually would say this has to be at least 6 months of treatment. I will try to offload the side using an orthotic or something, and I will rest them from high impact activities. So if it's medial, you want to shift them over to use their lateral side of their foot a little bit more, and vice versa. So try to offload it with an orthotic. Try to rest them from high impact. You could even boot these. I don't think it's wrong. You could boot them for 6 weeks or 8 weeks or something like that. Anyways, if they hit 6 months, they're still symptomatic, or there's clearly a loose piece, I'll offer them surgery. And they're young. I don't think this works in anybody over, I don't have a specific age cutoff, but as soon as I'm starting seeing 40s and 50s and 60s, definitely 50s and 60s. 40s I'm already thinking, oh, I'm not sure. The chances of having a kissing lesion on the other side, on the tibia, is very high. The chances of having the bone having any kind of regenerative capacity, I think, it goes down. So there's some definite factor of age, but it's the same thing. Like a younger patient probably heals it on their own, So when you look at these, sometimes they're really obvious and the piece is lifted right off and it's very easy to get to, and you pull it out and you scrape it down and maybe you drill a few holes in it. I'm fairly aggressive drilling through. I'll drill through the malleoli. So on the medial side, we have a little guide that makes a hole through the malleolus, and then you can change the position of the ankle and drill through that hole. So you do make a small kissing lesion on the distal tibia, after saying kissing lesions are bad. You make a small lesion on the tibial side, and that gives you access to it. I think that's a better thing to do than a medial malleolar osteotomy, which is cutting the medial malleolus and doing the whole thing open. It's a little crazy. You have to do that for maybe very rarely for an osteochondral allograft or autograft transfer procedure, like an Oates procedure. But anyway, sometimes you look at them and you go, well, I don't see anything there, what should I do? Some people believe in retrograde drilling that, so you leave the cartilage cap on and you just try to retrograde drill it to stimulate healing into the bony part of the lesion. I'm more of a believer that you just take it out. It's diseased cartilage. There's no, the cartilage is fed by, if you think about back to biology, the cartilage is fed from the bony side and then also from the joint side, but not that much. And so if the bone underneath it is not well, you know that this is not well cartilage either. And it's usually
separated.
Yeah, it's usually already separated. It tends to actually be a bit of a nightmare surgically, where if you start to get really aggressive, you realize that, oh my God, like all of this cartilage is peeling off, and then your 10 by 7 or 11 by 8 lesions, obviously a lot bigger than that. So I too very carefully try to preserve edges and stimulate new cartilage. How do they do? I've reviewed a zillion papers on this. In the US and in Europe, they're doing MACI and ACI on these things to try to augment them. People are taking, I remember one paper, they tried to take cartilage from the ostragonum and then grow cartilage stem cells to put back into it, like all kinds of shit. Microfracture here, I would say the standard 80% is probably accurate, which I hate saying because it seems like nary is a published study that says anything but 80% good results. But it's probably true. I'd say 4 out of 5 patients are pretty happy. And there's some bad players in there. Bad players are smokers that tend not to operate on them. Overweight people, very high BMI. And if this is a fundamental problem, I think this is really as definitely as a surgeon you have to know this. As a primary care MSK person, really think about the alignment, because you can do a few non-operative things for alignment. And a surgeon that is taking somebody who has malaligned foot, so I'm not talking something in the range of normal for a hind foot. I'm talking something severe one end or the other, and if you have a lesion, it's the same thing in the knee. If you're a severe varus or valgus and you have a problem on that affected side, it's very hard to make those people better, surgically or non-surgically. And it's the same in the ankle, okay? So if they're a varus hind foot or a valgus hind foot significantly, and they have a lesion in their talus that is on the more weighted side, it's very hard to make those people better. Those people are probably better to a foot and ankle reconstruction surgeon and change their hind foot shape. That's sort of what how I tend to treat it.
What's your estimate of the medial dome asymptomatic osteochondral lesions?
Oh, I don't know. Have you seen data? Are you asking me how many people walk around having them?
Yeah.
I don't know. That'd be a really good study. I don't know. Is it being done? It's probably.
I think the Reds say it's like 25%.
Yeah.
So that's pretty high.
Yeah, I would believe that.
Really?
Yeah. I would have thought it was maybe even higher than that. Yeah, probably it's probably age correlated or something.
Oh, sure.
Anyways, what you're looking for at surgery, I'm more of a driller than a microfracture. Bit of a surgical thing, may not be that much interest to you guys. Microfracture awls are conical in shape, and they never really have a good angle to go in. And so when we're doing a microfracture with an awl, you end up, the awl moves, so the hole goes oblong, and there's a higher level of fracture of the subchondral bone because the pressure is greater. A drill with a K-wire, drill with a K-wire is sharp on the same side, and so it makes very clean holes. It leads to less collapse. You're also not banging it in, it's going in with a drill. When you bang something conical in, of course everything moves. collapse down. That makes sense. But then people that like all say that the drill creates heat, which kills cells, and so like whatever. But nobody knows the difference.
So did you do that knee as well?
I'm a driller in the knee as well. Yeah, it makes the most beautiful pictures too, because all the little holes are perfect. It's like it's good. It makes you feel better about it. Did I go the wrong way? Yeah, so it feels about 60% better. Still unable to run. Still having trouble wearing high heels. That's a problem sometimes for some patients. I remember this patient actually. She ended up becoming friends with my wife. Don't ask. She was one of these people that had this chronic synovitis in her lateral gutter, even after I did her ligament and cleaned it out. And so we injected her a couple of times. It finally went away, but it takes forever. I don't know what to do with those people. If anybody has noticed that similar problem and has had any strategies for that, I would love to hear it. This is a good one. I think these are always. It still never amazes me that like old medical school textbook thing that like I was running and somebody kicked me in the back of the leg. Like they all say that. Like it's crazy. Like you can't even script it. It's like I never believed it, and then you go into practice and you're like, yeah, you tore your Achilles. Like before they just start telling you the story, like yeah, you tore your Achilles. So, anyways, this is a big problem in this age group of my own age group now, unfortunately. The sort of like 35 to 50, I think is probably the heavy one for this weekend warrior type. So, what do you guys do for your approaches to Achilles tendon? Everyone here is initiate functional rehab, London protocol.
I mean, I still depend on their level of activity in terms of, I think this is one that's still debatable, in terms of the surgical route versus conservative for.
Yeah. So what are your thoughts? What do you think about it?
If they're a, very active individual and they're concerned, there's high impact, so a lot of running, jumping, cutting, I'll usually have them referred for a surgical consult.
Just get the opinion.
To allow them to make the decision themselves, and if they choose not to, great. There's obviously the risk both ways.
So you don't send everybody; you just send more.
Select population. But yeah, you definitely can get great results from conservative.
Agree.
I mean, same sort of thought process, but I think if they're tendinopathic, I think they're. I guess then all of a sudden you think, well, probably whatever benefit would all of a sudden be exceeded by, like the tissue, I guess I would imagine would be really poor to begin with.
Yeah. Yes, I don't know what the right answer is in the patients that have had significant previous tendinopathy or at least symptomatic. I actually just had this guy. This is not the case, but he had an old tear. When he's around 50 now. He had an old tear maybe when he was around 28 or 30, and he had it fixed, but it was complicated by infection. So he had like multiple debridement and everything, and he had horrible tendinosis and a massive haglin. And of course, what happens? He's out playing again. It's like power to him. He like keeps going through all these injuries. The guy's a maniac. So he's out playing and he tears his Achilles. But not only does he tear it, it pulls off the piece of bone from the haglin and it's open. So there's a little like a little transverse laceration about 2 centimeters below. I should have my fellow put this case next time. 2 centimeters below his old surgical wounds, which look like shit because he had it opened up like. I mean, it's all closed and everything, but everything is all matted down. It's all scar tissue. The whole back was in scar tissue. And sitting there, like, resident texted me a picture of it because the emerge doc was like, you should come, ortho needs to consult this. I was on call. It wasn't like into my clinic. And I'm like, wash it out and like, we'll get some imaging and close it and give him some antibiotics and we'll see him in the clinic. Which I don't know in retrospect if it's the right thing to do or not. Anyways, we ended up getting an ultrasound. It was very bizarre because part of the native tendon was still attached to the calcaneus, and part of the tendon was attached to this piece, which had clearly broken off and caused the laceration. And the wounds look good, like, well, by the time we like saw, we put him in Aquinas and a removable splint, blah, blah, blah. By the time we saw him, it'd been 7 days, and everything was healing nicely and looking good. He still was Thompson negative, like there was nothing happening, so I was worried. So this was the one time I called the radiologist myself, and I'm like, I need an MRI on this. I need the whole thing. Because like if you go back in there, like I don't know what the hell I'm going to encounter proximal to that, right? Because he's had previous like multiple debridements and all this stuff. Anyways, long story short, the MRI showed that the ultrasound was not that good. Excellent ultrasonographer. I think it's just a problem of the tool. And there was still a good amount of attachment left. And so I was like, you know what? And I'm like, I didn't know the answer. Like, I really didn't know. I'm like, I don't know what to do here. And I said, okay, well, let's leave it for another week and see it. And then he came back at week 3. He still healed nicely, and now finally, like, he started to show some connection. And he was negative. And I was like, thank God. I was like, thank God. Anyway, so my take on Achilles tendon, I agree with you. We don't understand this. It's one of these weird things where there's been like 6 or 7 randomized trials, and we think that the chapter's closed. Jumping athletes, I think, are going to generally be maybe a little bit less satisfied. But my personal feeling, and this is my own bias, the money is on the length of the overall muscle tendon unit into the bone. So that's what predicts power. So if you look at all of these other studies, there's maybe a 1% difference in re-rupture rate, which probably has no it's not clinically meaningful. And then you trade that off versus whatever wound. Talk to the other guy with the wound healing problems, right? So for me, it's always about how much have you lengthened the entire unit of the. It's almost the same in a rotator cuff, to be honest with you, of the insertion of the bone, the tendon, and the muscle. So I look at the gap very closely. If you look at all of the randomized control trials, and most of them are 2 or 2.5 centimeters and less. And some of them don't specify in what position and how. And I think this is an area that we could do a really good job on a personalized medicine type of basis to try to understand an individual and how their power might correlate based on the length. So if I get an ultrasound and plantar flexion, we put them in a removable. I send them to our MSK radiologist. They keep them in the position of immobilization. They tell me the gap length or width in neutral, or however they're going to lie, and then they tell me in how we're going to put them in appointments. And if it's small, if there's none, there's like no question. I'm talking about like a 30, 40, or 50-year-old very athletic person. If they're not athletic and there's a gap that's under 2 centimeters, it's like, forget it. I agree. But I believe that there's some sort of individualized level of overall lengthening that will be tolerated that will correlate with push-off power. So if they're less than 1 centimeter, I usually tell them no surgery, because I think that they would have to be a 25-year-old, at which point, or whatever, like a really young, really active person, at which point those trials probably don't have there's no external validity of those trials for that patient. Those trials are all this patient, right? And then if they're in the 1 to 2, I'll have a discussion zone with them in terms of like, what are the pluses, minuses? I don't really know the answer. I think you're in a zone where, so if it's a really tall dude, I'll also kind of like put it to the person. If it's a really tall guy, maybe 1.5 centimeters is not that important. If it's a short person or a shorter female, that's where I think we could understand a lot better individually. And you have a good side right there to compare. Like, how long is it from the calcaneal insertion to the musculotendinous junction? That's what I want to know. And if it's going to be more than a threshold on the other side, I am willing to bet, maybe not my mortgage, well maybe because my mortgage is too high, but I'm willing to bet that that you could correlate that with post-op power that they can achieve, which is what I think athletes really want to know. So if they're over 2, I usually will fix them. If they're in the 1 to 2 zone, we'll have a discussion, and if they're under 1, I'll usually tell them no. So that's my personal sort of feeling. This was an interesting case because this person had an ultrasound. They said there was a high-grade partial tear in the proximal Achilles tendon. It was managed by an orthopedic surgeon in one of the community hospitals a bit north. this area measured 2 by 1.5 centimeters. There was a hematoma. They said there was a few millimeters thick remaining intact fibers in the proximal tendon in the back, and also, as an older person, there's an enthesopathy distally at the insertion of the tendon. So on the basis of that, the patient was may have. So this is there's 2 learning points I think in this is that these proximal tears are difficult, and I don't know what the right answer is for them. I think they're a different kettle of fish than the sort of transition zone, usual watershed zone ones. And B, that this person still might have been able to get away with it if they were treated properly. I don't really know what this, I don't know, does anybody do something like this? Anyways, he was not really, I think, treated appropriately because he was told he could walk on it. And he walked on it and he flattened his cast. Okay, so I don't know if it was the person treating him or what the patient says or whatever. He's like I remember this guy now because he's the husband of our CEO's secretary. So our CEO, of course, emailed me saying, "Can you see this person 3 months out?" He's got at this point in time, like we could talk all day long about muscle tendon length, but he had no muscle left. It's like I don't know where his calf was. Like there was nothing. So he basically had nothing on exam. Hopefully this plays. Things to note on here.